I would like to welcome you to today's webinar in our InBody Presents series. Today, Dr. Jessica M. Brown and Dr. Dan Shackelford from Carroll University will talk to us about cancer rehabilitation and Brown's FACE program. Dr. Brown is an assistant professor of exercise science with a focus on applied clinical practice. Her work on the use of prescriptive exercise to attenuate the harmful side effects and toxicities associated with cancer and its treatments is used across the world, and her FACE program is recognized as a significant model for exercise-based cancer rehabilitation. She has pioneered the Carroll University Rehabilitative Exercise or CURE program, an experiential learning-based exercise program serving the community. Dr. Shackelford is the program director and an assistant professor for the Master of Science in Exercise Physiology program. He believes in exercise as medicine for chronic diseases with a focus on cancer survivors, as many of the detrimental side effects of chemotherapy and radiation can be offset by the effects of exercise. As a pioneer in the field, he has developed cancer-specific exercise protocols and has assisted in the creation of a cancer rehabilitation model that is used by hospitals throughout the world. At the end of the talk, attendees will have a chance to ask questions to the researchers by adding them to the Q&A section. Without further ado, here are Drs. Brown and Shackelford.
And hello. Well, thank you very much for InBody for inviting us to this webinar. We are very excited to share our work and our research with everyone involved. So I will. Great. So as we're introduced, we are going to be discussing cancer rehab as a whole, and also talking about Brown's FACE program. So here are some very basic facts and figures regarding cancer. So cancer is the second leading cause of death in the US today, second only behind cardiovascular disease. Even though it's second, cancer is rapidly growing in diagnoses every single year. Even though cardiac is still the #1 cause of death, cancer is the leading cause of death in 22 states right now in the US, and it's still growing every single year. So unfortunately, these diagnoses and these deaths are still on the rise. Currently, right now, there are almost 17 million people in the US with some type of history of cancer. This year alone, they are projecting to have about 1.8 million new cases in the US. So out of every death that happens in the United States, about 1 out of every 4 is going to be attributed to cancer, unfortunately. So you break it down, almost every single day, roughly 1,600 people are going to succumb to cancer. And to make it even more, I think, impactful, when it comes to genders, 1 out of every 2 males in their lifetime is going to be diagnosed with cancer, and 1 out of every 3 females is going to be diagnosed with cancer. So it's a relatively high rate or chance that we will most likely be diagnosed at some point with cancer. And of course, this places a huge burden on the healthcare system itself by costing over $216 billion every single year. So that is obviously very troublesome, but due to advancements in treatments that really try to attack cancer, like we can fight back. We have extreme advancements in treatments such as chemotherapy, radiation, immune therapy, hormonal therapy, so many new ones on the rise there that the overall survival rate has increased. The 5-year survival rate right now is about 69% when you talk about all cancers together, which is great. And we found that every single year, the survival rate increases slightly every single year, very slightly, but it is increasing, which is very, very encouraging. So these advancements in treatments are amazing. However, all of them have a very, very negative connotation when it comes to the side effects. A lot of them result in very severe side effects, such as cardiotoxicity. So anything with the heart itself can become damaged due to, say, chemotherapy. A lot of cancer survivors may experience cancer cachexia, which would be the loss of body composition, which we can detect through InBody. So it's really neat to actually detect that. We see immune dysfunctions. They are more prone to becoming sick, which can lead to other diseases as well, or infections. We can see complications when it comes to the lungs. A lot of shortness of breath, even just at rest, may occur because of the damage that chemotherapies or radiation do to the lungs. Some cancer survivors might have peripheral neuropathy, where they lose sensation in their extremities, like their fingers or their feet. And the most common side effect out of all of them is going to be cancer-related fatigue. So this is fatigue that is just pertinent, and it's going to be persistent. It does not go away even with rest. So due to all of these severe side effects, now of course that's not an all-inclusive list, there are many more out there, but due to these specific severe side effects, cancer survivors really need to be referred to an exercise-based cancer rehab program.
And cancer rehabilitation is a common term, and it's synonymous often with physical therapy, PT, occupational therapy, and other modalities. But for the purpose of this presentation and with the PHASE program, we're referring to specifically exercise-based, because the offsetting side effects we're going to see that come from exercise and the benefits of exercise are deeply, deeply unique and independent of all other forms of rehabilitation. So we have seen, this is actually a figure from a textbook by Dr. Carroll Schneider in 2003. We have seen that exercise can reverse and almost completely attenuate all of the negative side effects as a result of cancer and its treatments. Cancer and its treatments cause debilitating physical side effects, such as cardiovascular dysfunction, cancer-related cachexia and muscle wasting, decreased muscular strength, muscular hypertrophy, and psychological stress culminating with decreased quality of life. And all of these together cause debilitating cancer-related fatigue. And we learned as early as 2003 that exercise can offset this. Exercise increases muscle mass. It improves left ventricular dysfunction. It causes heart improvements. It reduces depression. It reduces fatigue. It improves quality of life. And yet, decades later, we're still talking about exercise being beneficial, and it's because the education has still not been out there. And so again, showing this figure from 2003, we'd like to think that with work like this in these presentations, that we can truly show how beneficial exercise is and help get the education out, so this becomes standard care for cancer survivors. So there are some reasons and challenges as to why universal exercise-based cancer rehabilitation is not more prevalent. And one of the first issues in this topic is in relation to the exercise itself. As exercise physiologists, we have specific principles of training that are our dogma, that dictate our prescription of exercise. And these principles, such as individuality, treating the patient as a one single unique individual, progressive overload, acknowledging that for exercise as a stimulus to be effective and continually effective, the dosage has to be increased safely and steadily over time, but it must increase. And other principles such as reversibility, we think of this as use it or lose it. You have to continue developing a lifestyle of exercise to continue seeing benefit. That it is not simply a doing, it is a learning process. And other principles that are less important for this presentation. But one of the major issues with exercise-based cancer rehabilitation is that those who understand the use of the principles, primarily individuality and progressive overload, that they ignore these principles and that they err on the side of such extreme conservation and such extreme care that often we do not either treat the person as an individual, we ignore all of the multitude of side effects, or we do not increase the exercise dosage enough to see results. And for those who are untrained in exercise principles, it makes perfect sense that across the board, cancer rehab is violating and ignoring these principles, making the interventions less effective, thus reducing their adoption across hospital systems. The other major challenges for universal exercise-based cancer rehabilitation is in regards to money. Cancer rehab is currently not billable through insurance, like cardiac rehab is or physical therapy. And without that avenue for hospitals and clinicians to help accrue compensation for their work, it makes it extraordinarily challenging for systems to utilize this despite the clear evidence of its effectiveness. Likewise, there's no standard education for clinicians and medical professionals on what information and education and credentials are necessary for clinicians to work with cancer survivors. There are tons of different organizations, tons of different certifications, and everybody is doing something a little different with varying levels of success. And finally, most programs violate the principle of individuality because they treat all of the patients the same, regardless of the cancer type, the treatment status, or any of the debilitating side effects. And since each of these side effects, in addition to the client's unique medical history, contribute to an exercise prescription, this violation of individuality negatively affects the outcome of the individual or of the exercise. And finally, many groups offer group exercise for cancer survivors, which, although is better than nothing, is not as effective as individualized one-on-one care. And we can see this time and time again. Every patient is different across the board, but cancer patients uniquely are the most challenging for clinicians to work with because you have the individual, you have the medical knowledge or the medical background, you have the cancer type, the cancer location, the cancer stage, the treatments, and all of the compounding comorbidities that come with that. Therefore, with exercise, one size does not fit everyone, and that is a challenge.
So that leads us to the creation of Brown's FACE program. So all of those obstacles that we are currently facing for exercise-based cancer rehab has been addressed by Brown's FACE program. This overall FACE training is going to be dependent completely on the patient as an individual. It doesn't place a person in a group. It treats them with their specific side effects, their cancer, their treatments. So again, individualize the person based on where they are currently at as an individual. We really focus and base all of our training and rehab techniques and plans based on the individual's specific phase, their medical history, and their physical assessments that we do, one of which is going to be InBody as well. So these phases are going to be, the term phases are going to be very similar to cardiac rehab phases. And the term phases was chosen because this term is already established and very easily understood in the world of insurance. So if we can translate the cancer phases and relate them to cardiac, we feel that this might be an easier stepping stone to getting this into insurance companies to start billing that through insurance. So
much like the nomenclature with cardiac rehab phases, there are 4 sequential phases in the phase program, and each of the phases is geared towards a specific timeline on the cancer continuum, i.e. from the beginning of treatment all the way to the conclusion of treatment and the rest of life. Phase 1 is the first phase, and it is geared towards clients who are actively going through chemo and radiation treatment. The goal of phase 1 is to use prescriptive exercise at a low to moderate intensity to attenuate the deleterious effects of chemo and radiation. And the goal is to prescribe just enough exercise to safely, without negatively affecting the immune system, to offset the damage from the treatments. Some patients may see little improvement in physiological parameters, but the goal is that there is no declination in physical performance as a result of treatments. The treatments are not damaging to healthy tissue. And really the goal here is to do this phase for the entire time during treatment or for the remainder of a 12-week period. We will see that each phase is geared to be 12 weeks essentially in duration.
So people always ask, how do you know this is effective for those going through treatment? Well, we measure many variables that measure cardiac strength and psychological variables. Right here are going to be some very, very significant improvements that patients in phase 1 have seen. So cardiovascular fitness, or VO2 peak, has improved by 13% while they're in treatment. Upper body and lower body strength have also significantly improved, which is great for those who have cancer cachexia. And we also see a reduction in fatigue by up to 25% for those who complete phase 1.
For clients who transition from phase 1, i.e. they complete treatment, or for clients who begin a rehab program after treatment is concluded or with surgical or hormonal treatment, so they have no chemo or radiation, these clients move into phase 2. And phase 2's goal is to build a foundational base using functional and corrective exercises in conjunction with progressive overload to increase the exercise intensity. Phase 2 is a very integral interdisciplinary phase in which an exercise physiologist is extraordinarily successful with working together with a physical therapist and/or an occupational therapist. The idea with phase 2 is to utilize moderate intensity exercise to offset all of the lingering side effects of treatment and to begin to build the patient's stamina and all of the physiological variables. The other goal is to work on all of the areas such as core, pelvic floor, shoulder girdle, and range of motion, and to progress from closed chain, safer exercises to open chained, more proprioceptive exercises. Phase 2 is the idea that if you build a house without a proper foundation, the house is unstable. This is the foundation phase, and it lasts for 12 weeks.
And just like we saw with phase 1, after a client completes phase 2 in its entirety, just about every single variable that we measure significantly improves. So cardiovascular function, upper and lower body strength, and again, fatigue continues to see declinations.
Phase 3 is for clients who graduated phase 2. And this is where we really up the ante of exercise programming. This is the one phase where we truly adhere to the principle of progressive overload to the greatest degree. In other words, we make the intensity of exercise moderate to high, because at this time point, if you do not push a client, you will not continue to see physiological improvements. And this is the time point that most rehab programs either stop or ignore the principle of overload and make the intervention too easy. At the end of phase 3, if the overload and the prescription of exercise is correct, clients should improve in all physiological and psychological variables to complete apparently healthy status, because that in itself is the goal of rehabilitation, which is rarely achieved in most programs. You want your patients to be normal. That is the goal of rehab, to feel like they never had cancer. And at the end of phase 3, that's what happens. Another goal of phase 3 is to teach intrinsic motivation and self-efficacy. The idea is that to reduce reversibility of the exercise, you have to teach your clients how to do this for the rest of their lives. And this level of behavior modification is sorely lacking in most exercise-based programs.
So when clients finish phase 3, we continue to still see improvements in VO2 peak and in strength as well. Now, these improvements may not seem as great as the first 2 phases, but what you've seen though is that by this phase, usually they're classified average when you compare to the apparently healthy population. And what Dr. Brown just mentioned, that's ultimately our goal, was to get cancer survivors back to the apparently healthy condition that they were before diagnosis.
Phase 4 is really the indefinite remainder of life phase. This is for clients who graduated phase 3, and the goal is to continue adopting a healthy lifestyle and exercise. We recommend keeping the intensity at moderate intensity or higher for the remainder. This is not the time to drop the intensity of exercise because you've had success, because we know that if you don't use it, you will lose it. And this is your time to make exercise and healthy decisions a part of everyday life. We recommend group fitness for this, open gym, much like a gym, and one-on-one is always an option, but at this point, it's not necessary. This is not true cancer rehab. Cancer rehab ended at phase 3. This is the adoption of a healthy lifestyle. So with this figure, we can see that this is looking at cardiorespiratory endurance. And the point of this slide is to show that by not violating the principles of exercise, by utilizing the phase program, we can see in the gold huge improvements that in the end are doubled from other previous programs not utilizing this model and not utilizing the ideas of individuality and progressive overload. I think that seeing a doubling of an improvement is in itself pretty telling. And again, you can see this depicted here in this table. You can see huge, significant improvements from the beginning to the end of the rehab program in all of our major physiological variables, including a 30% reduction in cancer-related fatigue, showing without doubt the effectiveness of exercise-based rehab using the phase program.
So as we know, exercise has been time and tested, proven to be very successful in attenuating almost all of the side effects caused by cancer and all of its treatments. And we know that exercise-based cancer rehab should be a very vital component in a cancer survivor's rehab plan. So of all of those challenges that we saw with cancer rehab, in order to make exercise-based cancer rehab a standard in healthcare, we need to adopt some type of universal structured model. And we feel that Brown's phase model or program could be this model because it's going to allow for individualized progression that's going to be dependent on each individual cancer survivor based on where they're placed on the cancer continuum. So through our research, through years and years of research, we found that Brown's phase program has resulted in very significant benefits. It has been established as effective and reliable. And really, we feel this could open the door to make exercise-based cancer rehab billable through insurance companies, which is really so far the biggest obstacle that we are facing today. So we'd like to thank InBody very much for inviting us to this webinar. And we would like to answer any questions you might have.
Thank you so much, Dr. Brown and Dr. Shackelford, for presenting today. Now we have some questions the attendees would like to ask you. As you discussed, there are different types of cancer that affect different people, differently because of location, severity, drug interactions. What kind of factors, tools, and assessments do you use and consider when you are designing a specific personalized exercise program for a cancer rehab patient?
Monica, the question was which types of information, such as medical history and assessments?
Besides the, like medical history, you have to do physiological assessments, right?
Yes.
So what kind of parameters do you use to be able to design that personalized exercise program?
Yeah, so essentially cancer and its treatments will affect every major system in the human body. So our job is to measure every single one of those. So in addition to obviously cardiorespiratory endurance, we'll look at vitals, we'll look at muscular strength and muscular endurance, and we'll look at body composition. We use the InBody heavily because in addition to telling us body composition, it also gives us a measure of segmental lean analysis, which is extraordinarily helpful for designing interventions for patients who've had surgery on one part of the body or radiation. We can actually see the different lean tissue and actually train those areas with different prescriptions. And it gives us a measure of intra and extracellular water, which can help us be more aware of potentials for lymphedema. And looking at phase angle, which is correlated with patient mortality and effectiveness of their chemotherapy. So really we're looking at the heart, the cardiovascular system, we're looking at the musculoskeletal system in relation to muscle endurance and strength. We're looking at body composition. We do various range of motion, functional screening tests, gait, and flexibility assessments, as well as psychological screening such as depression, fatigue, and quality of life.
Thank you so much for sharing that. Yeah, quality of life, a huge point for, for cancer rehab. That's one of the main goals.
Exactly.
As you discussed also, research has shown that physical activity after breast cancer diagnosis and any cancer will decrease the risk of death compared to sedentary women, particularly in breast cancer. And there's a 2005 study by Holmes and others that showed the greatest benefit was from walking 3 to 5 hours a week at an average pace. According to the things you discussed and based on your experience, do you feel a steady state cardio like the brisk walking is more advantageous, or is it preferred to incorporate resistance training as well?
Sorry, go for it.
Okay.
Yeah.
We both are excited to answer that one. It's a great question.
Yeah. Mm-hmm.
I think that so obviously any exercise is beneficial. And obviously you can see that doing a walking program is beneficial for breast cancer survivors. However, the one thing I would caution is that's only working on one system, essentially the cardiovascular system. And it's ignoring really the musculoskeletal system, which for breast cancer survivors is often affected by estrogen blocking medications, leading to osteoporosis and bone and mineral loss. So I would recommend adding in a resistance exercise component using closed chain resistance exercises that help stimulate the bone marrow and stimulate really the musculoskeletal system to offset those treatment related side effects. The other thing I would caution is most exercise interventions in research only track the survivor through a short window of time. And we don't actually see any additional overload of the exercise, no increase in stimulus. So many of the improvements that are made initially may not last for the survivor without an increase in the intensity of the exercise, if that makes sense.
Yeah, yeah, that makes sense. So you have to continue through life and increase intensity to keep
Exactly.
it. Perfect. Um, so also, like one of the questions that we have is, what would your advice be to patients undergoing cancer treatment who may be fearful of incorporating exercise into their routine? How do you think we can best bridge the gap between exercise and clinical care?
Sure, I can answer the part about a client that might be fearful of going into exercise. I think sometimes when people think about exercise, they think about like really large guys in the gym, or they think about people sprinting up a treadmill, as fast as they can. And that may be a reason why they may be a little bit fearful or a little bit intimidated by exercise. So when it comes to cancer rehab using exercise, this is why we heavily use Brown's FACE program, because every single cancer patient is going to be different. Someone might be a novice, or they have been sedentary before their diagnosis, or maybe they were very active. So this program is going to really help us make more individualized decisions for this person's exercise intervention. So if somebody is, say, sedentary and they're diagnosed with cancer, and they're very nervous about starting exercise program, we take, like Dr. Brown mentioned, all of those initial assessments to get a very basic baseline of where they're currently at. We don't just do physiological assessments, we also do psychological assessments. So we take their temperament and how they feel, or their fear about exercise, also into the equation. We obviously don't want to push them too hard based on their cancer or their treatment, but also we don't want to scare them away. So if you use Brown's FACE program, it really takes each person's or individual's both physical and psychological, um, I think, factors into the equation, making the exercise both safe and effective.
Yeah, and I would say that the biggest barrier for patients, particularly those going through treatment with beginning exercise, is the fear that the exercise dosage will negatively affect the patient's immune system. That's one of the major consequences of overdoing it, so to speak, with exercise. And that's why, again, the program really designs phase one in a way that it is at a dosage that is successful, but a dosage that keeps the intensity low enough that there is no immune declination, and patients don't have to fear being susceptible to illness with the onset of exercise.
Okay, yeah, that sounds very important, very individualized, and making sure you're doing no harm, right?
Yeah.
So here's a question from one of the attendees. They're thanking you for sharing all this information. And they want to know what body composition changes the most from when you have cancer. I imagine with the cancer rehabilitation, what changes the most and what improves the most?
With body composition alone?
Well, what can you see in body composition? I think that's what they're asking. What body composition changes can you see? Yeah.
Yeah, that's a great question. Honestly, it will depend on the treatments that the patient received and their medical status. For some patients with breast cancer, gynecological cancer, prostate cancer, we often see increases in adiposity and decreases in lean tissue. So at the start of a rehab program, we would utilize the InBody to determine that. And the goal in each 12-week phase would be to see a reduction in adiposity and an improvement in the lean tissue. On the flip side, many patients with advanced stage cancer, such as stage 4 lung cancer, stage 4 colorectal cancer, or esophageal cancers, will experience cancer cachexia, which results in a loss of both adipose tissue and lean tissue. And in that case, our goal is to improve both components, primarily lean tissue, through the use of higher resistance training to offset that. And so I would say that body composition changes are dependent on the patient's treatment status and what their treatments are causing. And our goal, of course, with the rehab program is to return to healthy physiological standards with body composition. And that's another thing that's very beneficial in being able to see what the norms are as we're progressing each time we use the InBody and assess.
Thank you so much. Another question here is there an established protocol for an individual's type of cancer?
That's a great question. Because even with cancer type being unique, each patient is still so different in relation to their age, their other comorbidities, and their treatments for that specific cancer, that we have general recommendations for each type of cancer, but the exercise programming itself is more related to the whole total picture based on the phases themselves and the treatment status as a whole. And other than specific exercise recommendations for each cancer type, the dosage of exercise does not change based on cancer type, nor cancer stage.
Okay, that makes sense. Also, I know you have additional forms in your paper about what kind of exercises to utilize in the program.
Mm-hmm.
Can you give us a little bit of examples of what those are?
So for example, a typical session with a client is typically 60 minutes, 2 to 3 days per week. In a perfect world, it would be 3, but often with the limitations of scheduling, it's 2. And a typical session would begin with vitals of the patient, a cardiovascular exercise component, followed by a resistance exercise component in which we'll incorporate functional movements based on ADLs and incorporate balance therein, and then following up with range of motion and flexibility. And during the entire session, we really focus heavily on behavior and lifestyle modification and really utilizing those behavior change models to help change behavior across the entire lifetime. And so that would be a typical session. Now, the dosage of the exercise and which exercises specifically, that is going to be completely dependent on the patient's medical history and their assessment results. And that's why we think that the roadmap that the phase program offers is very effective. It shows dosage, it shows intensity, it shows progression, but there is still enough variability inside of each of the components of cardio, strength, balance, that makes it truly individualized.
Okay, thank you so much for addressing that, Dr. Brown. Here is a question that I think is very important because it's something that you will encounter in practice. They're asking, how will you explain to a client that exercise won't feed the tumor and won't promote the spreading of that tumor?
Yeah. You want to talk about it a little bit?
Oh, sure. Yeah. So that has to do a lot with, honestly, like metabolic pathways and how the tumor is going to respond to exercise. So tumors itself are going to be like any other living cell in the body, right? They want to live, they want to thrive and survive. And the way that they do that usually is going to be taking a lot of the body's nutrients, like carbs that are going to be converted into glucose. So tumors themselves can steal glucose away from healthy tissue. And unfortunately, tumors can go through this process called angiogenesis, where they're going to create their own blood vessels. They're going to feed themselves. So that's just a terrible side effect of the tumor itself. So one thing that exercise is going to do to help someone alleviate their fear of making the tumor worse or bigger, well, first of all, when somebody exercises, the working muscles like the chest, the legs, the calves, the quads, they're going to require nutrients. So instead of the tumor stealing the carbs or the glucose away from the body's going to naturally transition and shunt the carbs or the fuel towards the active muscle, which is going to deprive the tumors of that glucose that they're trying to steal away. So exercise itself is going to be a good way to kind of divert the body's natural fuel to the working muscles because of exercise. That's one way that exercise itself can actually help attenuate the spread or the enlargement of the tumor itself.
Yeah.
So.
Okay, thank you so much, Dr. Shackelford. Here we have a question from a lymphedema specialist. How often do you look lab work when you are working with a patient?
How often do we, what? I'm
Do you
sorry.
look at the lab work?
Oh, okay.
Lab work, lab work.
It depends on the patient, and it depends on if they have diagnosed lymphedema or not. Typically, to be honest, most of the measures that we look for lymphedema are circumference measurements at either the axillary upper arm area or right below the inguinal crease in the upper limb of the leg. And then utilizing changes pre to post in our intra and extracellular water from the InBody. When it comes to lymphedema, we are not the experts. So we tend to listen to the specialists and the oncologists based on their recommendations.
Okay, thank you so much. Have you seen any recent progress or signs of exercise-based cancer rehab becoming billable?
Yeah, I mean, I would say that you can see exercise being used more prevalently across the country and across the world. You can see programs such as the YMCA's Live Strong. Many different universities have small programs. And you can see that there are different certifications through different organizations. A lot of people are utilizing exercise more than they ever have before. I think the concern is that there is no continuity or standardization of not only the credentials and the training, but the education and the exercise prescriptions itself. I mean, it is growing. It's just not growing in a standardized way.
But we are seeing progress though. For example, a couple of years ago, there was a hospital in Hawaii that actually wanted us to come to their specific hospital and start up their own cancer rehab program through their own departments. So hospitals are starting to see the benefit of having this exercise-based component to the rehab programs. It's just, again, that the education isn't as universal as we would prefer at this time.
Yeah.
Well, that is really great news. And actually, I have to tell you the webinar has been so interesting for people that we have been receiving so many questions. So we have, I think it's getting people thinking a lot also. Somebody actually is asking you, which version of the InBody do you use in your research and in the clinic?
720?
The 770, I think the more advanced version, 770.
Okay. And what kind of metrics do you use then when you're looking at each individual person?
With the InBody?
Yeah.
So we almost use all components. I think the one that we use the most is going to be the segmental lean analysis and the segmental body fat analysis as well. We like to see what parts of the body have been affected the most by the cancer or the treatment. So with the InBody, we can look at how much muscle mass they have on each individual leg, the core, or the arms there. So we can actually then use that information and tailor that and make it even more individualized for their exercise prescription. So I would say the lean segmental analysis is what we use the most from the InBody.
Yeah, I'd say the lean tissue and the adipose tissue for actual dosage and prescription of exercise. In my research, I've been focusing on the visceral fat measures and the phase angle pretty heavily, looking at reductions in visceral fat and then improvements in phase angle over time. And we're looking to compile and publish research on that before we start using that heavily as prescription methods yet.
Thank you so much. Also, somebody wanted to know, how often do you look at blood work, WC information from the physicians to monitor patients during their exercise training?
I'm sorry, can you repeat that?
How often do you actually look also at blood work, WC, things like that also?
Yeah, great question. For patients who are in active chemotherapy and radiation, looking at blood work such as immune function would be the integral time. Typically, only if there is a concern does the oncologist and us communicate regularly back and forth. Most of the time after phase 1, looking at blood work is something that we do at pre and post assessments, which is at every 12-week interval, but not generally something we do inside of those 12 weeks.
Thank you so much. There's another question here, like, since it is, a phase program and it's very specialized and individualized, do you see this being at any point included in a gym environment?
Yeah, that's a good question.
I think so, and I hope so. In fact, through previous students of ours who have gone out and want to spread cancer rehab, a lot of them actually start in a gym setting. They'll start very, very small. They'll first take on a couple of clients. They aren't their own clinic, obviously, yet, but they start their own cancer rehab program and they recruit cancer patients to the gym. So I think it is very possible and very doable for cancer survivors to be in a gym setting if the correct program is in place and if the person has the correct information. Obviously, ideally wanting to be within a clinic, but if that's not possible, I think a gym setting would be very doable as long as, again, the proper precautions, especially with cleanliness, are followed.
Yeah, I'd say as long as you have the education, the training, and you can follow the right prescription, you can honestly do cancer rehab anywhere that's safe and cleanly. And as long as we're in the COVID era, everything is cleanly. So essentially,
Yes.
this is fair game.
Yes, that's completely true. Here there's another question that I think is very important, because there's also a lot of literature about cancer survivors in the children, pediatric population. Are there any protocols for pediatric cancer patients? Assessments, interventions? Could you apply the same model, or how would you change it for a pediatric population?
That's an excellent question. I would say that there's two major factors to consider with pediatric rehab. The first is most children with cancer, many have a liquid type of cancer, which tends to lead later to cardiac dysfunction and congestive heart failure later in life. So the most important variable to focus on in children is cardiovascular health, so aerobic exercise. But the challenge is the prescription is valid using the phase model, in that you need to achieve a moderate intensity of exercise based on where the child is on the cancer continuum. But children don't want to do structured exercise. So we've had a couple of graduates move into pediatric oncology rehab, and the goal is you must disguise the cardiovascular and functional exercises as play. So essentially you've got to, it's very difficult because you've got to find the intensity of play that is the appropriate dosage of exercise. And I think that you can follow the same protocols. It's just more challenging because you have to make it more fun.
Yes, definitely. Yeah, they don't want to be, in a structured, boring kind of setting, and probably wouldn't give the same results either. So it's important to keep it fun for them.
Yeah.
So it's also interesting you're having already some of your students going out there and working on things like that. That's really great.
Yeah.
And given that, we've received so many questions, I think we could never stop, but I actually wanted to ask you both one question to each of you. First, Dr. Brown, after proposing the phase model for cancer rehab that is being used in other centers, as you stated, and having the paper with Dr. Shackelford recognized as a paper of the year by the ACSM, and congratulations to both of you, actually.
Thank you.
What is next for you and your work? How do you see it going, Dr. Brown?
Yeah. Well, obviously, I'd like to continue with educationally with helping spread the knowledge that exercise-based rehabilitation works. I mean, ultimately, I think to feel successful, I would like this to be a standard of care for every cancer survivor, across the world. When you are diagnosed with cancer, your world changes. And I believe that we are missing a very integral component in the survivorship plan by not having this available to every single patient at every single moment when they are diagnosed. And I think that my goal is to continue helping with this education with webinars like these, and for every student that graduates with this training to hope that they can go and create this, because every single one of us who has the training, who does this and touches a cancer survivor, that is the change. From a research side, one of my goals is to continue fine-tuning some of the exercise prescriptions and continuing to utilize different assessment measures to continue that process and to expand to other types of chronic disease.
Thank you so much. I really enjoy the passion you have for this. One question related to your answer there. How can we help support the mission for the use of cancer rehab?
Yeah, I think that we all have to collectively work together to find the right level of education, and then to utilize a universally standard model so that patients are getting a level of care that is effective and has been proven. And I think that each one of us just needs to go out there and continue to have the conversations, the hard conversations with those who are controlling whether these are in hospitals and insurance billing, and whether that be us talking to our legislators and those who are higher up. It's our job to advocate that cancer survivors deserve this level of care, and this should be billable through insurance. I guess long-windedly, we need insurance to pay for this. And it is our job, every single one of us, to continue shouting, because this has to change. There is more research now on cancer and exercise benefits than there is on exercise benefiting cardiac patients. Yet every person who has a heart attack is offered cardiac rehab. And there should be cancer rehab right there along every step of the way. And we all have to advocate for that change.
Thank you so much. That's really a great point. And now, just to close up, Dr. Shackelford, do you have any closing remarks about how you're starting this field and where would you like it to go?
Well, just like Dr. Brown, I think spreading the information, I think education, just awareness is going to be our biggest advocate to really help expand this into the healthcare world itself. So really, I think we're in an exciting time right now. I think we're about to see this huge push for cancer rehab to be involved in every single hospital across the world in the United States. So I think it's just an exciting time to be in this exact moment, to be a part of this movement, to make it available to every cancer survivor. Because like Dr. Brown mentioned, this should be available. It should be an option to every cancer patient out there. So we're just excited to be a part of this movement to make it universal in every hospital.
Great, thank you so much. Okay, I really want to thank you both, Dr. Brown and Dr. Shackelford, for taking the time to talk to us today.